The talk for tonight was suicide awareness and prevention and what to say to those who may be at risk. And I think if you came hoping I had all the answers, it's probably the wrong room. What motivated me to do this is really in my work in mental health, particularly when I had worked with young adolescents who had been diagnosed as having a bipolar illness or schizophrenia. There were not only children, but also their parents who would say, maybe they would be better off dead rather than having schizophrenia. And I didn't know a whole lot, but I knew those were the words that no one needed to hear. For us, I'm talking about the team at St. Joe's, the talk I'm going to have tonight about suicide prevention and what to say is part of our continuous commitment to improving care and trying to learn along the way. So I expect that there will be people tonight who will have words of wisdom, things that I will also learn, and at the end we are inviting people to share. This talk came about because probably about 8 or 9 months ago, I was asked to give a talk to a group of parents who had teenagers, and they were really concerned because it was making the news, that children were dying by suicide, and it was not only what do we say to our children if we think they're at risk, but what do we say to them when their friends tell them they're at risk? Because that was another concern, that young children were, asked to keep secrets, and secrets that no 15-year-old should keep. So this is really kind of how this is developed. What I hope you walk away from tonight is that you have a sense of the warning signs, that you feel a little bit more comfortable on what to say and what to do, and that I really do hope that you walk away with a better understanding of what we're doing at St. Joe's and how we would like that to continue. If you came to my interview room at Parkwood Mental Health, this is actually the sign that hangs on the front of my interview room, and hopefully you can see it. It says it's okay to ask for help. The young lady who painted it knows I'm sharing it today and actually had seen part of my presentation. And this was a young lady who struggled with suicidal ideation and now has a blog to advocate for other young people. But it's the message I want people to see when they walk in my door. So Jody mentioned a little bit about the statistics. So today in Canada, 11 people will end their life. 210 will attempt to end their life. And often a question I get asked is, do you think the suicide rates are increasing? And when you look at what the data for Statistics Canada, there has been a slight increase in the data in 2011 and 2015. The numbers that are probably the most concerning is that for people who are adolescents between 2008 and 2015, the numbers doubled. It's the 9th leading cause of death in Canada, but the 2nd when we're talking about people under the age of 21. And you don't have to go any further than the London Free Press. This was an article on May the 10th. I have it dated at the top. But that the OPP in the Elgin area received calls for 3 suicide attempts in the hour prior. And what the article encouraged people to do is to reach out. So the warning signs: talk, what people say, their behavior, their actions, and really I think what you observe about their mood. So when we talk about talk, it really means we have to be willing to listen. And I think that for many people is the most important. It would be not only are you hearing what I'm saying, but are you willing to listen to what I'm saying? And I've seen patients, I've seen clinicians ask questions to patients in a way that I think, well, there's no way a person's going to say no. It would be like when my grandmother no longer had pie and she said, Sandra, you don't want any more pie, do you? Well, of course my answer is no, I don't want any more pie. We see, both clinically and in life, that people will go, so you're doing better now, right? You're feeling safe now, right? So how easy is it for people to go, no, actually I'm not? So things you need to cue out, because sometimes people will share that they feel trapped. And you may not feel that they're trapped, but they may really feel that in their life there is no other option. They may feel hopeless, have no reason to live, talk about really that their symptoms are just a burden to the people who care for them. Comments like, well, my family would be better off if I'm dead. They may talk about being in unbearable pain and seeing no way out. And sometimes people are as forthcoming as saying, I should just kill myself. Or it may be comments like, I go to bed at night and I pray that God won't wake me up in the morning. And the question is, and what do we do with that when people talk about there's no way out? We see that for many people that they just, and we've all been there in the middle of a crisis, that we actually can't see the forest for the trees, and we often may feel that we can't avoid it or escape it. The behaviors that people will often talk about and identify may be the increased use of alcohol and drugs, looking for a way to end lives, so people searching the internet, asking questions. And sometimes not only, because there's websites out there, if you don't know, that will tell you not only how to do it, but will tell you how effective each method may be and how painful it may be. But people will also look online for ways that people that they have admired have died, and try to emulate those techniques. So for me, particularly when I worked in an adolescent population, the death of someone who was famous and comments like, how this person died, were really conversations that were important. For, the one I remember the most, because I would have thought it would have been rock singers and stars that have died by suicide. It was actually Robin Williams. That for many of my patients were saying, but he was funny and he had a wife and he had children and, and he had a whole career. If he saw no reason to live, why should I? And then would share what they understood about how he had ended his life. And, and their level of curiosity about that was absolutely a warning sign for me to go, why have you been looking into that? Often people will isolate themselves from family and friends. They may sleep too much or sleep too little. I had a lady who was assigned to my care. She'd had a disagreement with her previous psychiatrist, decided she'd like a female psychiatrist, so I had agreed to assume her into my clinic. We met once. She needed an adjustment in her medications because she could no longer afford her meds, so she had stopped them and said, you can put me back on meds, but it has to be something my husband and I can afford. Her second visit to me, she came with this beautiful present that she had made. I'd met her twice. It was a bit atypical that people, now if you know me and you love me, I can see why you'd all want to give me presents. But to meet me for the second time was a bit unusual. It wasn't Christmas. And and everybody was, as I went to the waiting room to get her, everyone said, oh, you should see what she made. It's beautiful. And I'd heard about it before I saw it, and I thought, oh, this is not beautiful at all. I knew she was struggling with her mood. And, the first question I asked, I said, this is absolutely beautiful. Can you tell me why you brought this for me? And she shared that the reason she brought it was she was so relieved, because I was the physician lead for the program, so she called and said, I need a female doctor, and this is why. And I said, you're in luck, I'm female, and I'll be your doctor. But basically, it was her gift to me to thank me for helping her get some coverage for the medication she needed, which was really all my job, and she wanted something that I would remember her by. She was admitted to hospital that very day. I thought she was going to take out 2 security guards as we tried to get her into the hospital because she was not going willingly, and said, I regret giving you a present. And I saw her last week, and she's very excited because she's going to be a grandma. But those things, those types of things about why would you give me that book, why would you make me this present? She was quite talented, and the gift was quite intricate. So the deal was I held on to her present while she was an inpatient, and we returned the gift to her, and I told her when I retire she can give it to me again. And just the way the pension plan works, I've got another 17 years, so we're good. Also calling people to say goodbye. For young people it may be text to say, I'm really sorry for what I did, I hope you forgive me, or apology calls. And it may be, some of the behaviors may be more aggression, irritability, or even fatigue. So it can be quite subtle. These behaviors are really important, particularly in light if they have been related to a painful event, loss, or change. So if someone's response to, a breakup in a relationship, an illness in a family, being let go from a job, being disciplined or criticized at work, and for adolescents, a loss of a fairly significant relationship. These types of things are absolutely things we need to pay attention to. Certainly we know, I think one of the things that I found very interesting doing the research when we got involved in the zero suicide is, I actually assumed that more people who died by suicide were clinically depressed than actually what the literature bore out. we certainly have to be aware, that if people are clinically depressed, anxious, the symptoms of depression, such as loss of interest, irritability, those types of mood, or feeling, humiliated or agitated or even full rage, those are things we need to be clinically aware of. But oftentimes people will die after what they perceive as a loss and they see no other way out. And the question I often will say to people is, you've just shared with me that your mood's been really low for the last 2 weeks. Has it ever got so bad that you've had thoughts that life isn't worth living? People are often reluctant to ask about suicide, but is that not how you would ask? Because if you don't ask, people won't tell. The benefit of how that question is asked is, I know you told me you're sad, but you've got such a great family, so clearly you're not thinking. And sometimes we ask that, not just as clinicians, but as people, because we're almost afraid to hear the answer. So what I'm going to go through is a little bit about what can you do if you suspect a loved one is struggling. So we've kind of done a little bit already. What are the signs to be aware of? What would you do if someone gave you a book or a prized possession or sent you an apology call or a letter? And you have to be direct. You have to ask the person if they're considering suicide. And if the answer is yes, if the answer to the question of, absolutely, I have thoughts that life isn't worth living, my next question would be, have you thought of a plan? There's often a myth that if you ask people about suicide, that somehow they'll think about it. But that isn't true. I have one person who's actually ever said to me, and I've been in London doing mental health since 1994. I had one person who said to me, no, I haven't had thoughts of suicide. Should I be thinking of suicide? And then got quite anxious. Unfortunately, this young person had OCD, so in retrospect. But then we had a great discussion because it turned out they were having thoughts. And she's like, I don't really want to die, but my OCD makes me have these repetitive thoughts, just like I have thoughts that things are germy. And so it turned out her initial response was like, oh my God, I shouldn't have asked that question. So it is a myth. Asking people if they're having thoughts of dying doesn't make them have the thoughts. Asking a question like you genuinely want to hear the answer and that you're prepared to hear the answer. It's not like I'm leaning against the door, I'm looking at my watch, that people will give you, yes, I'm having thoughts. No, I don't have a plan, but I pray every night that God will take me. Or, I have a plan. I don't think I'll act on it today, but I've been stockpiling my meds for the last 3 weeks, 3 months, 3 years. You also have to take all threats or attempts seriously, and I think that's often where we don't. I saw it probably a little bit more in the adolescent world, that adults would say to me, well, they took 10 of whatever, that can't kill you. And that was irrelevant. That's absolutely irrelevant. What was relevant was, to say to a person, so Bob, when you took the 10 pills, what did you think would happen? And sometimes people thought the 10 pills would kill them. Also, it's important to be non-judgmental and empathic. I've sat, over the years and would hear families and friends saying, what do you have to be depressed about? When I feel sad when life is actually going pretty good, that's depression. So for people to say, well, you have nothing to feel sad about, well, depression doesn't work that way. Do people feel depressed even when life should be going fairly good? But we've seen that. My personal favorite was hearing someone say, I'm being quite facetious because I realize people don't know me here. They're like, do you know what that's going to do to your mother? To this poor child that had tried to end their life. To a child that was already struggling with thoughts that he was a burden. So those things are very important about threats or attempts. I actually shared a story earlier today in my work. I saw a young fella, and by young I mean like 17, and he was fair handsome. That would be a Newfoundland expression. It means he's really handsome. But he was fair handsome. And he had overdosed on medications. And to complicate this, his father was a physician and he was able to access medications that his father had. And although the amount of medications he'd taken would not have been fatal, he didn't know that. His father went to medical school, this teenage boy did not. And when I sat and met with him, he had shared that his girlfriend of about 3 or 4 weeks had broken up with him. And she had broken up with him in a very public way. She was his first love. And he was pretty convinced that his life was over. Now, we all have sat here and we all have lived through life and went, the first love at 17 is not your last one. We all probably would be very quick to say, oh, but you are smart and you are handsome and you are funny and there are fish in the sea. Like there would be lots of comments that we would make. But it was very clear when I spoke with this young man that this young woman, because it's part of adolescence, it's called narcissistic mirroring. But for this young fella, when this young girl said, I don't love you, what he heard is, you're not lovable. This was a young man who looked at me and said, I really regret that my parents found me. I wish they had come home later. I know everybody thinks this is not such a big deal, but my life is over. He too got admitted to hospital. His mother was relieved, his father was livid. And I remember, having that discussion with the dad, and the dad said, I'll never forgive you for this. And and basically the kid wasn't really so happy either. But I remember, my thought to them was, I don't really care if they all hate me when I'm 80 and he's 80. But no one was going to like me that day and for him not to be safe a few days later. Because, I had an old lady lens. I had an old lady lens that bright 17-year-olds that are quite attractive were going to find someone else who thought that they were cute as a button. He had a different lens, which is why, I use that example because it was a serious attempt for him. And he really needed to meet at that moment, he actually didn't see another way out. He was embarrassed and he thought that life no longer had meaning because somehow he was unlovable. So this goes on so you can't minimize the feelings expressed because he got a whole lot of that. And I think a lot of young people who make attempts get a lot of that. You were bright, you're attractive, you got your whole life ahead of you. But that doesn't kind of speak to, the depths of despair they may feel. So you don't use the cliches like many fish in the sea. A better question to ask is, is there anything I can do? It's been fascinating to me that people will say, if I just didn't have to do X or Y, I might be okay. Now, sometimes people may ask you for things you can't do, but the question of is there anything I can do is kind of similar to asking, are you having any thoughts? It shows I'm listening and I want to help. If you can, you draw on the resources in the person's network. I think what's more important also is not to be drawn into secrecy. We see that with young people, that their friends will share with them. Because I started this with my children. My daughter is a fair bit like me, but kinder and gentler. But people tell her all their problems. Like if you know her, you would tell her your problems. The problem with that when you're 15, 16, 17 is that people tell you problems that 15, 16, 17-year-olds shouldn't have to deal with. And and she's the world's best secret keeper. And when that was how we started having this conversation, that it wasn't her secret to keep. That she couldn't promise that to her friends, and nor should she promise that to her friends. What she should promise to her friends is that she's there to support them, but we need to find the right person to help. Be it, do we need to talk to your mom? She was actually very lucky in her high school. She had a phenomenal guidance counselor who was quite supportive in her school. But, as an adolescent, you needed to seek out the right support. A few months back, I gave a talk to and forgive me for I probably get the name wrong, but it's a women's council. So Deb, I'm looking at you because you were there. What's the proper name? There we go. And I had 2 or 3 women who came up to me at the end. So this is a group of very bright, articulate, intelligent women. It's kind of like where I want to hang out. And it was a fascinating group. And women came up to me to share stories about, my friend called me and told me this. I'm worried about their safety. There were 3 different people who came up to share and how they had been holding the secret, not really sure what to do, and not really sure about how to find, more appropriate support. So they were doing all the right things, but one woman was like going, I came here this morning and thank God she answered the phone, because I go to bed every night not knowing if she's going to answer it in the morning. What can I do? So we did a little safety plan about what she could do. But that would be a very important thing that, not, because, particularly in my work in adolescence, I would never start with, you can tell me anything, it's completely confidential, because there'd be nothing absolutely worse than me saying to you, trust me, tell me, and then I go, oh, but actually I have to tell people. This is the same young lady. It's hard to read, and I apologize, but I'll read it. It says, "You will not always be strong, but you can always be brave." She actually painted this for me. She spent almost the best part of 2 years in a hospital. She was assigned to me my first day I went to St. Joe's Mental Health on the Tuesday after Easter Monday in 2015. And she was quite at risk. And she says, this is what I said to her. I'm pretty sure this is not quite what I said, I think. But I know what I would have said to her, because she was on constant care at the time because she wasn't safe. I probably said to her, my job is to keep you safe. I just need you to be brave. Because, if you're not feeling strong, you don't have to be strong. I will be strong. We will keep you safe. So this is also in my office. But it kind of, it goes, for me, why this was really important is because in that conversation we had, that's what she took from it. That in that moment, she just needed to be brave because we were going to carry her until she was safe. So, words truly do matter. And I'm quite fortunate, because I should knock on wood, because she is doing quite well. What else can you do if a loved one is struggling? So remove any obvious means. One of the other things that was very interesting about the literature was that if someone tells you that they have thoughts of harming themselves with a gun or a rope or with pills, is that if you actually remove the gun, the rope, the pills, that the majority of people don't actually go to a plan B, which I thought was fascinating, but it probably speaks to when people are so overwhelmed and so distressed that that's their mindset, that removing what people have identified. It also says you're listening. So if you were my patient and you said, well, I have thoughts of harming myself, but not today, Dr. Northcott, but I'm stockpiling my pills in case that comes, and often people will tell you, if my cat dies, if my mother dies, if I get evicted, then I'll take the pills. Like often people, and it's not meant to be anything other than an acknowledgement of, I'm holding on for this reason, which is also an important question to ask people. But, so when they say to me, I'm hoarding my pills, so then, the conversation is, so what time are you coming back today with all your pills? If I think they're safe enough to do that, or, can someone go out with you to get your pills? Or, you need to come in today to hospital. Can we call your mom, your brother, your best friend? And in an acute crisis, you take the person to an emergency room. I know when you hear about the poor ER, my apologies to LHSC, but if that's where people need to be, or sometimes walk-in clinics may be for people, a mobile crisis team if one's available, and there is one available here in London. And the other advice I would give people is don't leave people alone until you have some support in place. So that may be waiting. The other piece about what you can do if you suspect someone is struggling, because often that's the question people ask of me. So my friend said they're not safe, but they refuse to go to the hospital. What do I do? Depending on the circumstance, it may be that you call the crisis line, and they may send out the mobile crisis team. It may be if the person is at imminent risk in that moment, and I hate to say it, but we do involve the London Police. I have called the London Police. I received an email from a person, a medical student, many years back, and the young lady had emailed me to tell me that she was going to kill herself in the hospital. I tried paging her, I tried calling her, I couldn't reach her. So I called the police and said, because we knew where she was, and I couldn't get at her, which kind of probably speaks to, and said, because I thought, is she in the hospital or has she gone back to her home? And I called the police, and someone said, well, you can't call the police. She wasn't your patient, she was a student. And I'm like, anyone can call the police. If you feel someone is at imminent risk, you can call the police. For patients who have a known mental health illness, families can go to a justice of the peace and get a Form 2 to have someone brought into the hospital to be assessed. It's not the route anybody wants to do, but that's often the question people will ask me about. Someone has told me very clearly they're not safe, they have plans to do it, and I don't know what to do. It would be no different than what you would do if you were driving down Highbury Avenue on the bridge and you saw someone climbing to the top of the bridge. You would call 911. The acronym that people often use is the TELL. It's what I tell my patients. The T is for talk. If you're not feeling safe, you have to tell someone. Unfortunately, for many of my patients, they have to tell more than just one someone. They have to tell many someones before they get help. They need to, they may need to ask for help, and we need to ask them if they're safe. We need to listen to what they're telling us and not kind of minimizing it. And then summarizing, we need to keep them safe. I've shared, these are the contacts here in London, so reach out, both their phone number as well as, you can go on the website, you can web chat with people. If you connect with them, they can also call 911 or a mobile crisis team, as well as the Crisis Center on Huron Street, 648 Huron Street, and the emergency department at LHSC. So, even within our community, those are kind of the people that we would reach out to. I'm going to shift gears a fair bit and talk a little bit about what we're doing at St. Joe's. So this idea of zero suicide actually first was brought to my attention a few years back at one of the St. Joe's tribute dinners. So I was sat there with Paul Links, who was the chief chair of our department, and I think he had been talking to Michelle a bit earlier in the evening, and as we were sitting there waiting for Howie Mandel to present, he said to me, "The foundation has money, and I think what we should do is we should roll out zero suicide on the inpatient unit, the mood disorder program. It's a 24-bed unit." And there's nothing, I'm like one of those go big or go home kind of girls. And I'm like, "Dr. Links, if we're going to do it, can we do it in our ambulatory care program, which had 1,300 patients? Thanks. So with the foundation support, we were able to launch this initiative. So a little bit about why. So this is a program that had been started at the Henry Ford Hospital, and they initially called it the Best Depression Model. And it was a program, an integrated model of care that with putting it in place, they actually went 9 quarters where they had no suicide for people who were part of their health management plan. Like, that was outstanding. In a state where the suicide rates had been going up, their suicide rates had gone down and actually had a period of 0. So Dr. Links had shared a little bit of that. But often when I give people my presentation about why we did zero suicide, those numbers were outstanding, but that was not my why. My why was the statistic that in Canada, in the month prior to dying by suicide, 45% of people who die by suicide will have seen their primary care provider. 45%. 10% will have presented to the emergency department or or an urgent type care program. 30% of people who die by suicide will have seen a mental health care provider. 30%. It said to me that, so they're connected with a psychiatrist or a social worker or a nurse, and yet the system still hasn't protected them. So what are we doing, and how can we do it better? So that one, those numbers were truly my why. It was also my why. So if you met me, I actually treat St. Joe's like it's my own personal bed and breakfast. If you came to Parkwood Mental Health, I know the names of the majority of patients, including those who are not under my care. It really is. It's like my 150-bed bed and breakfast. Come visit me, come join me. And when patients pass away, particularly by their own hand, I'm absolutely devastated. Sometimes a little bit even not functional. So this was very important to me because it said our model of care that we're currently delivering could be improved upon. And here were people at the Henry Ford Hospital, other hospitals in the US, as well as in Europe, who were showing that they could reduce their suicide rate. So it's based on the belief that suicide is always preventable, one suicide is too many, and blame is not productive. It's considered by the Ontario Hospital Association as its best practice, and St. Joseph's Healthcare London is actually the first hospital in Canada to roll it out. So we have successfully completed a pilot on our ambulatory program. Where we are currently, so this line actually, this is a Dr. Kernahan line. To get to a never event, we need always behaviors. And we actually saw that as kind of the model of zero suicide as we rolled it out. It's a quality improvement project. So we initially did it in our ambulatory program, and we're now, with the support of the foundation, beginning the work of rolling it out in our second phase, which includes our inpatient units at both Parkwood Mental Health as well as Southwest Centre for Forensic Mental Health Care. And this is a project that really has actively engaged the frontline staff, patients, and families in major processes and decisions. And a perfect example of that was we had committees that helped us with, we wanted to have what I called initially a crisis plan, because that's what I was used to in the City of London. And we had a patient who had joined us, a gentleman who is quite vocal about being a suicide attempt survivor. And we sat at a meeting with him, and he said, "I don't like the idea of a crisis plan." Sorry. And so we all kind of looked at him like, "Well, why don't?" Well, I thought, well, everybody wants a crisis plan, like in my own head. And he said, "Well, if you give me a crisis plan, it makes me assume that I'm going to be in crisis." Because we were going to do it for every patient, a plan. He said, "Can we not create a coping plan? Because the reality is we all need to cope." So we actually looked at coping plans. We use some of the work from crisis plans, but a coping plan would be when I'm really stressed out, I'm not calling my mother, but I may call my brother. I may go to yoga, but I absolutely shouldn't drink. Like, those are what coping plans look like. So when he said this, can we not have a coping plan that not only says what I shouldn't do, but what I should do? I got to tell you, sometimes it takes a lot to convince me, but I turned and looked at him and I went, I'm sold. And that was actually the level of patient and family interaction that we had in rolling this out. So phase one was with the adult ambulatory and our concurrent disorders program. So that's for people who suffer from both a severe mental illness as well as substance use. And now with our rollout, we're doing it in inpatient, and we're also working with the operational stress injury program, which is for people who are veterans. So both veterans of the military as well as people who work like first responders. So that's currently where we are at. I'll just do quickly the umbrella by which this comes, because it really is a strategy that looks at continual improvement within the system, and it really bases itself on leadership. Because you can imagine if you were a nurse or a doctor in my hospital and I said, I'm going to roll out zero suicide, there was a real concern. So if people die by suicide, are you going to blame me? Because the reality is, I'll tell you, as healthcare providers, when a patient dies by suicide, nobody else has to blame you, because you already blame yourself. So we were very clear that that was not what we were doing. This was supported from the organization. It was really about a safety-orientated culture. We wanted to dramatically reduce suicide among people under our care. And how we were going to do that is we were going to say, this is a priority for St. Joe's. And not only were we going to say it, we were going to put our money where our mouth was. We trained our staff. All of our ambulatory care team is trained in applied suicide intervention skills training assist. Every single clinician in our outpatient program, both in London and in Elgin, are trained. All of my staff were trained. We use a Columbia Suicide Rating Scale. It asks questions like, not only have you ever tried to hurt yourself, have you ever tried to, where you ended up in hospital, but have you ever tried to hurt yourself where you got interrupted, or where you may have abandoned the attempt? If you haven't tried to hurt yourself, what is the most driven you've ever felt? Our staff were all trained in how to do the scale, and new patients into the program were all given a lifetime rating, and now we're trying to catch up with the people who are into our program beforehand, and every patient on every visit has a since last visit assessment. So we trained our team in that. We actually trained our team in how to do a formulation, which really was, if the person sitting in front of you, what put them at risk, which was important, what could put them, what predisposed them, a previous attempt, depression, what put them at more risk, a loss, and what protected them. So that if you called me and said, Sandra, my cat died, I should know that part of what kept you safe is because you needed to look after your cat. If that, because, sometimes maybe their own clinician isn't there, so another clinician. We did that training, and people got trained in cognitive behavioral therapy, both general for people who hadn't done it before, as well as CBT for depression and suicidality. Because you maybe think, well, they all worked at a psych hospital, like how do they not all have it? But not all training comes with a mental health background, so recognizing that people had different levels of skill, there was a huge investment supported by the foundation to skill people up. And it was part of our commitment to say, we don't expect you to have magical powers and do this. We are going to give you the tools and the resources to help support you to do this. So part of the Columbia was that we systematically identify and assess suicide risk, and we do it at every visit. So if you don't do it, you have to document why you didn't do it. So if you were an occupational therapist and you took someone to the community to help them grocery shop, or you took them to the Salvation Army to get first and last month's rent, you may document that the person didn't have it, but that that you should be asking. Also engaging that every patient has a pathway to care that's timely and adequate, and includes collaborative. So we talked about safety planning. So we actually, for people who are identified at being higher risk, is that people do have a suicide risk management plan. Certainly we want to treat people using evidence-based treatments. I think pharmacologically we're excellent. I think psychological treatments we have room to improve on. One of the transition pieces, we know that people discharged from hospital or people discharged from a crisis center or after an attempt are at higher risk. So what we have put in place is that when you leave the hospital, you are seen with by a clinician and within 7 days of discharge. What we would like to do, our next step, is we're going to ramp that up even better, so that if you leave on a Friday and you're not going to see me until Thursday, that you're going to get a call on a Saturday or Sunday from the inpatient team to say, Sandra, you're home, did you get your meds, did you get settled, are you comfortable with your appointments, and are you safe? We put this transition, but this is a place we're also working, and improve. So applying data-driven quality improvement approach to inform system changes. According to Accreditation Canada, everybody should have a suicide risk assessment done if they're part of a mental health program. I'd like to tell you that was happening 100% of the time. That was not. But man, can I tell you how much better we are at it now. And that when you look at the numbers, they are consistently above 90% for coping plans, suicide risk assessments. So, this was really about, because really, who took the time to review every chart to go, is it being done? We've taken the time to review every chart to make sure it's being done. Like, this is the commitment that as an organization we have to safety. And if it's not being done, you get a visit from your coordinator to go, and how come you're lax? So these are the numbers. So 90% of patients receive a suicide screener at every visit with their primary clinician. 96% receive a lifetime suicide assessment. So I should tell you, my little girl who has OCD, I don't ask her every time she comes, because we've now agreed that that's not the question I'm going to ask her, because it puts her in a spin for 2 days. So I have to document. Clinician and patient feedback was incorporated. So we've actually revised our safety plans based on the feedback from our staff and our patients. And we know that there's still several opportunities for continued learning and skill building. We know that, and which is what we're working on, and also the opportunities like closer transitions in care. But our goal is really that there's fewer gaps in suicide care and that we've improved the standards and the quality. So that's a huge part of what we have been doing the past year. And as I said, we're going to roll it out, the next steps. So we're going to do it on the inpatient units, operational stress injuries with our veterans. Because, as you read, if you're on Facebook, can you do 22 push-ups to recognize the 22 veterans who die per day in the U.S.? And because suicide is the second leading cause of death for children ages 15 to 24, when we're rolling it out, a tool that would be useful in an adult may not be as useful in a child. So we're actually looking at adapting our tools, such as BASIS, which is a brief adolescent suicide ideation scale, which talks in language that kids would understand, and also identifies what puts kids at particular risk, so things like bullying. And the hope is really to move forward is to expand the tool to outreach, community agencies, family practitioners, and guidance counselors, particularly for the BASIS tool in particular. But really our next step, this is our step 2, and we do have a vision of what a step 3 would look like. A little bit more about what regional, I'm going to say regional mental health care London, but we're not that anymore. We're Parkwood Institute Mental Health Care Building. We've recently received funding for a Southwest Regional Indigenous Mental Health Pathway. And this was really important for many reasons. I think, because we want to ensure people have culturally appropriate care. But in the context of suicide, it is a group of individuals who are at higher risk. So, certainly integrating the zero-suicide work into this will be important. But as I mentioned, so the pathway is to have a culturally safe mental health care in the hospital. Really, we want people to have access to care that's timely, equitable, and coordinated. Really to enhance care in the community in order to support people living with serious mental illness. And what's really unique about this project, although I'm talking about it, is that although it's, there's a St. Joe's logo at the bottom of my slide, that this is actually an incredible partnership with community partners, and as I mentioned, Woolawook and Healing Lodge. If you have a kidney problem, there's another word you say. It's like, oh, there you are, glomerular, but I have to practice. Some words I get stuck on. So this will be, this is really, quite exciting work, and we were recently funded for this project. So it's kind of like, bringing it to the inpatient, developing a tool for child and adolescents, because that work is kind of unique to St. Joe's and the group of Dr. Fisman. It's been the basis has been validated in a research. We just need to get it out into the clinical world and our work with the Indigenous pathway. As I mentioned, what do I hope you get from this presentation? I hope you walk away thinking that you probably have a better sense of what some of the warning signs are. I certainly hope that you feel like you may have a bit of a better strategy, and also that you have a better sense of what St. Joe's is providing and really hopes to provide in the future. And I think what I definitely hope you walk away with, is I want you to realize and to share with people it's absolutely okay to ask for help. And I kept to time. There we go. Thank you.